Good morning, everyone. It's really a privilege to get to talk myeloma together this morning, although I know you didn't want Dr. Gertz to leave, so hang in there with me, and we'll continue the story because he really just left me at the perfect place where we're talking about new things. So we're going to talk about bispecific antibody landscape in myeloma. So Dr. Gertz was already telling you about the story of the weeds in the garden. And this is kind of a journey of our myeloma patients, isn't it? They come to us when they have symptomatic disease, and we treat them into remission. The resistant cells grow back, try to get them back down again, and it's become a journey that's really a little bit of a whack-a-mole, isn't it? So at the time when the cancer comes back, it's always a little bit harder to settle it back into remission. When we get to the refractory state, this just means that these cancer cells are not following the rule, and we need something better that's going to hopefully get it back down into remission. So this is where the stories start. So Dr. Gertz mentioned to you about medications that have been available. So I'm going to actually look back at the time up until the past 5 years. So what did we have? So we have immune modulatory agents, those Revlimid, pomalidomide. We have the proteasome inhibitor family, that's your bortezomib, carfilzomib, isosomib, or Nilaro. And then you have your antibody, that's your Darzalex, that's your isatuximab. Then there's a group of patients that have already seen them all, and they have refractory disease to all three families of drug. We call them triple class refractory. That's a group that we're worried about because, well, when we look at people like that who've been through more than 3 prior lines of therapy, the response rate actually go down quite a bit. Response rate for that 4th line is usually about 20%. We just don't have the greatest shot at these. And patients could have relatively poor outcome. Their survival is severely affected by the cancer itself. So this is really where era of novel immunotherapy comes about. My colleague, Dr. Mohan, is going to tell you about the CAR T. So I'm going to start with this bispecific. So what does it mean bispecific? Bi means 2. So it means that it has 2 grabbing arms. It's not a naturally occurring antibody. It's made in the lab. Normal antibodies that you and I have to fight infection, it actually has 2 sticky ends, but it grabs onto just one kind of thing. Say, for example, you and I caught a cold, right? Our immune system's turned on. Now you have antibodies going to go fight cells that are infected by the cold virus, which now have the antigen, the protein from the virus on the surface. The antibody that we make grab onto those infected cells, and it sits there. Now that cell is marked for destruction by the immune system, which will now need to go after those cells and clear it out. Well, the bispecific antibody goes further. It has 2 grabbing arms that grab 2 different things. So on one end, it actually grabs the T cells, that's your T lymphocytes. On the other arm, it grabs onto spot on the surface of the cancer cell. So it's like matchmaking. It's like you have a double-sided tape. Now you're pulling those 2 sets of cells together. And the T cells that swim around without ability to see and go after the cancer cells are now going after the cancer cells. So you'll see that. Oh, sorry. Did I just turn it off? Okay. All right. So the T cells are otherwise naive. They're quiet. They're not thinking that they need to do any work. When this antibody molecule goes in, grabs the T cells, grab the cancer cells, it activates the T cells, and these T cells are now pumping out all kinds of these like cytokines. These wake up other T cells that were actually sitting at bay. So now they're all waking up, right? And these released substances actually penetrate into the cancer cells and burst them. So you can actually have those T cells going to do the work for you. The beauty is, because it's designed to be so specific to the spots on the surface of the tumor cells, doesn't actually bind other parts of the body. So the right kind of antigen on the surface of the tumor cells were selected for development because they're so specific to the target. All right, so 3 products have been approved so far. Teclistamab is the first one. Elranatamab became available later, actually in 2023. Both bind on to BCMA, which we'll talk about in a little bit. And there is another molecule that binds onto a different antigen called GPRC5D. That medicine is called talquetamab. All right, so why BCMA? So BCMA is a protein that's on the surface of the tumor cell and also normal plasma cells. As the B cells grow to become plasma cells, it actually increased the level of the BCMA. BCMA actually help the myeloma cells grow. So if you actually block the BCMA, you actually stop the cancer cells from growing. It is also increasing expression as the cancer cells go from the MGUS state to the myeloma. So interesting and good target, not expressed in other places outside of those plasma cells and myeloma. And this is its function. It actually, I keep doing that, I apologize. Sits on the surface of the tumor cells, and it takes on the growth signal from outside, and then it turns on the downstream. It turns on the machine within the cells that makes the cells grow. All right, so the first drug that came about a few years ago now is called teclistamab, and this is the clinical trial that led to its approval. So first thing is you'll see that up here it said phase 1, 2. So clinical trials have 3 different phases typically. So phase 1 would be typically finding the right dose, figuring out the side effects. Phase 2 would be, does it work? And phase 3 is usually asking the question, is it working better comparing to the standard of care? So typically when we do a phase 1, 2 clinical trial, it's not necessarily to get an approval. It's just to get a sense. But this is a clinical trial that was so impressive in that they took patients who've had at least 3 prior lines of therapy. I was telling you that this group of patients didn't really have great choices, and their lifespan is projected to be 12 months or so. So this is a group of patients that include folks with high risk cytogenetics. 90% of them progressed on their last line of therapy. 78% of them were refractory to all of those 3 families of drugs I mentioned about. And look at the complete remission rate. This isn't just an overall response. Overall response was about 60-some%, but among those responders, there were people who achieved very, very deep remission, even in the setup where we really didn't intend to go in there to look for a response signal. So an expansion of this clinical trial actually led to the approval. And this is what happened. Not only they respond to therapy, but also, so this is the overall group. This is looking at the chance of patients staying in remission without progression. So the top 2 lines were the people who did the best, because in time, some of them have progressed, but good number of them have not. This is a group that have achieved complete remission or better. That's the group who are not quite there, but they're also achieving relatively deep remission, and this is the overall group. So all in all, quite impressive data, going from not having choices to give. So now people are staying in remission really at almost 3-year follow-up. Really in the complete remission group, more than half continue to be in remission. This is another agent called elranatamab, also that BCMA targeted agent, approved in summer of 2023, that same group of patients, although they are coming from the same family, they're actually intrinsically different in how they're designed. Still, relatively similar, high response rate with lots of people with complete remission. And if we look at the chance of staying in remission, the chance of continuing to respond to therapy, this is for the overall group, and the top lines were the people who achieved complete remission. So you'll see that although this hopefully will need to have a longer term follow-up. Hopefully it flatlines out for a very long time. So people who achieve deep remission can stay in remission for a very long time. The power is power of immune therapy, right? All right. So how about, I was telling you that there's also another antigen, another compound that targets something called GPRC5D, another spot on the surface of the cancer cell. That molecule is called talquetamab, and this is the clinical trial that led to the approval. Same kind of thing, people with advanced multiple lines of therapy, and they test 2 different kind of schedule, the once-a-week schedule and the every other week schedule. Both show extremely high response, but I actually am also encouraged by the group that have had prior CAR T cell or prior bispecific antibody, which is the last bar here, meaning that those people have already gotten the other kind of bispecific antibody and they still do really well with decent response rate. So it goes to say that we're having more tools on the shelf now to be able to help picking for our patients. And this is, again, looking at the duration of response in those group of patients. And this is separated out. People who respond very, very deeply and achieve complete remission continue to do very, very well. So 3 drugs approved literally in the span of 2 years or so. So this is really how they look a little bit different, right? So this, there are two that bind on to that BCMA, and there's one that bind on to different target. This group of drugs, they do have this unique side effect. It's called cytokine release syndrome. What is it? When you're waking up the immune system and they go to fight cancer, we're creating a war within the body, don't we? So when your immune system is fighting infection, you actually have those fever, chills. That's pretty common when you have a flu. So this is kind of like having a flu because it's turning on the immune system and having the cancer cells not being acting like they were actually the flu. Now, some of these patients, though, will have the war that's a bit big. The fever, if it's very high, can cause confusion. That's a neurotoxicity. It can also sometimes cause a decline in blood pressure or oxygen. So this group of patients need extra monitoring. So how do we do this safely? We don't turn on the immune system all at once. We would warm it up. So we would do something called step-up dosing. Many of these regimens are going to require a baby dose to start out with, and then in a few days, as long as you tolerate the treatment, then you go up to middle dose. In a few days, and you go up to the full dose. That's typically how it's done. Classically, that step-up dosing occur still for most places in the hospital. There's some programs now that start to expand this to try to do the step-up dosing as outpatient with collaboration between the doctor and the patient to try to do close monitoring without needing to bring patients into the hospital. These unique side effects, it sounds scary, but it's actually a story of the first few weeks. Once you get past that, the immune system is now turned on fully, able to go after the cancer cells. You don't keep getting this kind of side effects down the road. But what we need to worry about down the road is actually infection. Most patients will get some form of infection, but this grade 3, 4 infection, which typically means patients requiring intravenous antibiotics, patients needing to be admitted, it's not trivial. It's actually happening all through the lifetime of the patients as long as they're still on therapy. It can be up to about 30%. So what does this mean? It means that patients are also doing their part to help making their treatment work well by watching out for infection, right? If there is the need for vaccination, get them. Taking medication to help reducing the chance of infection. There are medication to prevent shingles called acyclovir that we typically use. We also use something called Bactrim, and that reduces certain unusual pneumonia. Patients also typically, because we clear out the plasma cells that have BCMA, they may also be having very low level of normal antibody. So they'll get replacement of something called IVIG. If you think about, we need you to have the level that's enough to be there for you, whatever come your way, and you're only able to make so much, then we'll bridge the gap by giving you that extra infusion. So sort of trying to go after the cancer while keeping people safe. Now, the talquetamab, that GPRC5D, actually has another set of side effects. Because GPRC5D, while it's present on the surface of the cancer cell, it also is present on some other cells in the body, including the skin. So the nails and also the groove of the tongue. So some patients would have outer taste. The mouth is very dry. Some will have peeling of the skin. So it's really all about, as you're launching on the journey of taking something new, understanding both the benefit and the risk. Because on the risk management, it's going to require a teamwork, right? So patients are going to be telling me about how their appetite might have been, how they're eating at home, and so on. And that'll help me figure out just how much medications they should be taking. All right, so those are side effects that we talked about. Early recognition and manage appropriately is the key. And this is just highlighting on infection. So this is the general guideline I tell patients. I was already sharing with you about the prophylactic antibiotic, the IVIG, and the Bactrim, and also the vaccination. It's also important to know who you call if you were coming down with infection, for example, right? Rather than waiting it out at home, someone should know about it. Now, this is the skin peeling that happens with the GPRC5D. While it appears scary, once we get past the first few cycles, it's usually just much easier to manage. But you can totally tell that this is significant dryness, and patients are going to need some extra protection of their skin. If side effects are significant, then we would hold the dose, let things cool down, let things heal up before we restart the therapy again. So now, exciting stuff. But why are we not stopping here? It's because bispecific antibody, even as great as it is, it doesn't work in everyone. And there are some people who it works for a while and then it stopped working. There are many ways why that would be the case. One of the ways would be the cancer cells learn to shut down the target. If the T cells, if the antibody molecule is grabbing on the T cell, on the other hand, it needs to grab onto the cancer. If the cancer cells decide, you know what, I'm not going to show that target anymore, I'm just shutting it down. So there's nothing for the molecule to grab on. That could be a problem. But now the good thing is we've already had two different products, right? Two different classes of agents. One will grab onto that BCMA, the other one grab onto an entirely different target. So if one spot is shut down, you at least have another spot that you can go about. And when talquetamab was used in patients who've already had that BCMA therapy, it still works quite nicely. So more tools there. And the right tool is probably really the sequence of using the right things one after another. There are also a problem of the T cells. If they are getting turned on, they're going to work for a while. They may actually start to get wimped out, right? They just kind of get, we call them exhausted. The fitness of the T cells are not there. So how are we going to help the T cells coming about? So there are medications that are getting tested to try to combine with those bispecific antibody to boost up the T cell function so that things work better. So, let me just tell you about a few other ways. So because I was saying that that BCMA molecule can actually get chopped off by this secretase, which is a molecule that's in the bloodstream and inside the bone marrow. So that little piece of target can actually kind of get chopped off, and then it just swim away and get into the bloodstream. Well, what if we can actually keep that target on without it being cleaved? So there is a medication, a pill, that can be used to block this chopping type protein to increase the BCMA expression. So on clinical trial right now. And there are many other targets on the surface of the cancer cells that can be targeted. So we're not going to be limited to just one or two anymore. This is an example of a medicine that binds onto something called FcRH5. So one arm, it grabs onto that FcRH5, the other arm, it grabs onto the T cells. So now, yet another group of drugs. This medicine is called cevostamab. It's already been in development for some time, and this is a clinical trial that's looking at it in relapsed refractory multiple myeloma. And they did include patients who have had prior BCMA type therapy. And this is the response result in the first 160-some patients, and you'll see that there are actually response across the board. So hopefully something that will keep our eyes out to see whether it's going to come through in the near future. Again, early results, but you do see very nice deep remission with also some patients whose response is so deep in that even if you look inside the bone marrow up, over 1 million cells getting evaluated, you don't find 1 out of 1 million, and that's your MRD negative group. That's pretty cool, deep remission that we can see in this advanced stage disease. Now, this is moving us even further. What if, rather than grabbing the cancer and grabbing the T cells, what if you can grab onto the cancer cell at 2 different spots at the same time? So if they're going to get snaky and shut down one spot, then you actually have 2 spots getting grabbed. Right, so it's harder for the cancer cells to figure out how to get around. So this is what we call tri-specific. So now we have 3. So this is an early clinical trial that was presented just at an International Hematology meeting last year. So this molecule, it looks like this. It binds on to the T cell and also bind on to, so this pink site grabbed to the T cells, but it also grabbed the myeloma cells at 2 different spots, at that BCMA spot, but also at another spot called CD38, which is the spot where your Darzalex or your isatuximab bind onto. So the cancer cells, if this is going to get sneaky, it's going to need to shut down both at the same time. It turned out that it's hard to do because both BCMA and CD38 are actually pretty important for the growth of the cancer cells. They would have a hard time shutting them all off. So this is an early clinical trial that was presented, so not so many patients, but they did include patients who have had prior BCMA-targeted therapy, CAR-T, bispecifics, and so on, and you see that response rate was actually really good. So stay tuned, but the clinical trial is now going to phase 2. Not only that, another company decide, well, how about we do by a tri-specific antibody that actually one grab onto the BCMA and the other arm grab onto the GPRC5D. So almost like the two different targets that we already have, two separate bispecific antibodies against, but this one's coming in one molecule. So that tri-specific antibody grab the T cells and grab the tumor cells at two different spots. It also is able to grab two different tumor cells at the same time. Because if one arm grab onto the T cell, one arm grab onto BCMA on one cancer cell, it still has this available arm to grab on the GPRC5D on another tumor cells. So the whole idea is to bring the tumor cells and immune cells as tightly, closely together for that engagement and clearance of the cancer cells to occur. So this one already went through what we call a phase 1, that dose finding thing, and the phase 2 is already more than halfway enrolled. So stay tuned. Both are going to be first in class. It's in its own right. So what am I excited about going forward? I mean, of course, we're not in the business of saving the best for last. We have to be able to give this new technology to as many people as possible. So being able to use bispecific antibody earlier in the journey of patients with myeloma makes complete sense. The T cells would be fitter, patients would be fitter, cancer won't be so aggressive, right? Now, if we could combine it with something else that either boosts up the T cells or kind of come at the cancer cells in a different way, we like to think that there will be even extra effectiveness. We hopefully can help more people. We talk about some new targets, but you remember that I was showing you that, but there are also those many other sticky targets on the surface that they have been identified. They just haven't been all targeted yet. And how about if we combine bispecific antibodies together? It turned out that if you just use what we've already had today and combine that teclistamab, which is against BCMA, and talquetamab, which is against GPRC5D, clinical trial was already done to show that using them together, you don't need as much of either, but also you get so much more benefit in particularly difficult group of patients, including those that have this cancer, this myeloma cells not just living inside the bone marrow, but form tumor masses, and we call them plasmacytoma. So that clinical trial was very successful. So we'll see just where the combination of the two would go, but it also, in a way, indirectly telling me that the tri-specific really has probably the combination of both things on one molecule, and that would probably be worth looking at in that very difficult group of patients as well. Now, both you and I know that patients who are responding to treatment at some point were more worried about side effects, right? Because the cancer is quiet. But if we're keeping adding on side effects, then we could be in trouble. So how about being able to stop treatment at some point, use it less frequently at some point? So the different dose and schedules being looked at. In addition to that, I was telling a group of us who had conversation earlier that when you build your first car, you got to send the car out because someone needs a ride, but that's not the best car you can have. So there's so much technology that goes into tweaking what we have, tweaking the antibody technology. You can have it being able to grab the T cells in controlled way to try to decrease the chance of that cytokine release syndrome that keep people in the hospital. How about if it's actually not only grabbing the T cells, but also create this long-term memory T cell? So what are these memory T cells? They're what's going to remember the cancer cells and be able to be your surveillance down the road, even after you stop the antibody, because now you've trained the T cells rather than just use them as long as the medicine's available. Also, agents with longer half-life, meaning that it's not cleared so fast, so your injections may be a once a month rather than a once a week. How about those tumor masses, those plasmacytoma that I talked about? There is a concern that all of the immune cells, all of the molecules may not get to the center of those masses really well. How do we modify the molecule so that it gets to where it needs to go in a better way? So just this way, we really have equal access of the immune system to wherever the cancer cells live. So a whole lot to really be excited about. It's hard to say how many of our patients today may already be cured based on all of these new technologies, because what we need is time to prove that You'll just live the life that you're supposed to live and have the myeloma being part of the journey but not being part of the problem that end up shortening the life. But I strongly believe that these tools probably already provide a chance of a cure for someone. Really, the power is the knowledge, because a lot of these are going to change very quickly. And unless you know, particularly when the treatment is no longer working well in your situation, if you don't have the knowledge to have a thoughtful discussion about the pros and cons, it's going to leave you at the position to just rely on what's available locally. Some of these things may not be readily available where you're treated. If your doctor where you are collaborate with centers that have access, that's a double bonus. So think about, Dr. Gertz was talking about finding your care team. Who is your care team? It may not always be just a shop near you. Now, how many people have two sets of doctors, people who see you at home and people who see you once in a while? So I'm seeing lots of hands. So good deal. So I'm hoping that this would be where you get this extra information, but use patient support resources that's available to you, like what HealthTree has developed, because I think this is changing so fast. It will be exciting time. And I talked about relapse refractory to start, and I think that graph is pretty sobering. But just know too that oftentimes success can happen later, even after some early hurdle. And I think that a lot of these are going to change the way that graph is being presented in the future. Thanks very much.